Welcome back to the PFC podcast. The views and opinions you are about to hear are the speakers and do not necessarily reflect those of anyone else. Now on to the podcast.
Welcome back to the PFC podcast. This is Dennis, and this episode was recorded with the sponsorship and support of the Special Operations Medical Association. Thank you guys very much, and I hope you enjoyed the talk.
Hello everyone, I'm Pierre Pasquier, also called PP.
Yeah, my name is Lieutenant Colonel Florent Josse. I do not have a nickname.
The real one. We're here to talk about European medical preparation to measure engagement and large-scale combat operations. Well, it appeared quite important for us to share our thoughts with the SOFMED community here in the SOMA and to explain that Europe is getting ready to face huge issues. And especially in Europe, France and Germany are old friends, not so old, but old friends. And we are trying to put things in the right side to get prepared. We have no commercial relationships to disclose. It's our personal views. And I've got especially a very French accent, and Florent has a little German accent.
Yeah, and a little French as well, so that's, you have to excuse our English accent and pronunciation. So I think everybody will understand us.
So let's have a walk on the side and background. Ukraine is an example of what is a big threat. It's war at Europe's door. We are looking with careful attention the evolution of the war in Ukraine. In the French military, every week we have an update on the conflict. And we are trying to learn so much medical lessons from the field, and it's really, really useful for us to get prepared. The same thing in Germany.
Yeah, more or less. So that's, we are looking about, it's not easy to get all this information and to learn about. We just hear this morning, this learning is not only learned until we learned this lesson learned, but we have to care and to see and to adapt our behavior and planning. And sometimes we are much slower than the Ukrainians can change their thoughts and tactics. That's a big problem in Germany and France, I think, as well.
But by the way, it's a European medical preoccupation, and at the European Health Security Committee last January, the General Peter Iversens, chairman of the NATO Chief Comets, talked about civilian military cooperation on health preparedness, and he stated that a resilient European population with sufficient prepared healthcare capabilities and capacities to face and support a potential armed conflict with Russia is a deterrent. And it's a great observation, and our preparation, we really don't know if this war will come up to Germany or France, but what we know is that we are ordered to prepare to face this war. It's not only European preoccupation.
No, we see here on the slide, which is an official NATO slide, that on the Eastern Front we really have, and that is our goal, to work together, and that proposes that, so it gives us some big issues that to bring some nations together and say, okay, you have to share this part of the front is one thing, but this is a multinational approach, and sometimes it's not easy to get this approach in one nation. Now you have to work together with different nations. We will have a large number of soldiers on this line, and it's a multi-domain operation, so sea, land, air, and all this unconventional and informational things, so digital things and cyber. Yes. So that means, how can we bring these all together? And just we, for example, for Germany, we're responsible for Lithuania, but to bring all these different nations afterwards together and speak the same language, we will come later on it. This is the main issue. This is planning, but how can they talk afterwards on the ground and at least bring all these patients and casualties done back through Europe and afterwards through Germany as a hub. But this is one big issue I think we have to think about.
Yeah, there's a lot of soldiers to support in the field, and we should expect a large number of casualties. So we are preparing to face mass casualties. Here is an illustration comparing the combat casualty rate per day during the conflicts in the last century. From Second World War, Korea, Vietnam, Iraq and Afghanistan, Ukraine, and maybe Taiwan. So on the right, on the vertical axis, you have the number of the casualty rate per day, 100 casualty rate per day. In Iraq and Afghanistan, less than 10 casualties rate per day. In Ukraine, several hundreds of casualties per day. So we need to adapt our medical doctrines and to take into account this large number of casualties. And we even more have to take care about diseases and non-battle injuries, since there are more and more soldiers on the field. Some soldiers will probably be older than the ones who were deployed during the conflicts in the Middle East, and they will bring with them their chronic diseases, hypertension, diabetes, etc.
That means that we are not longer deployed, you and me?
We are not
anymore deployed, you and me?
Not yet.
No. Good.
There's also big issues about infectious diseases, because soldiers are staying more longer when they are wounded in the field. They pass through several medical locations, and they bring with them a lot of bacteria, including multi-drug resistant bacteria. It is a big focus by the international medical community. It was a paper published in Science 2 years ago. Some authors have even talked about a bacteriological war, a war against superbugs, and the goal is to stop them before they stop us. So they propose a biological warfare approach to safeguard European biosecurity. When a patient is hospitalized with multi-drug resistant bacteria, it is really heavy organization to take care of this patient, in particular to limit the spread of the multi-drug resistant bacteria, and to limit the risk of infection with some bacteria that sometimes may be inaccessible to antibiotherapy.
And we already had these problems by getting in Europe more than 5,000 Ukrainians for chronic diseases or chronic wounds. And that brings all these germs and bacteria to us, to the civilian or military hospitals in Europe, which makes a big problem for treating them. And sure, we can learn about it, but this is a big issue at the moment already. And we are talking only from a few casualties and not from mass casualties coming. Yep.
Yeah, also illustrated in the conflicts in the war in Ukraine, there are more and more dangers for medical teams. This is a map of the numbers of attacks on healthcare facilities since February 2022. There was almost 3,000 total attacks on healthcare facilities, not only in the border of Ukraine with Russia, but also deeper into the country. That means that we need to adapt our organization for medical support and location of medical treatment facilities. We need to improve our medical treatment facility organization.
Yeah, not only the MTFs, but we have also to improve our mindset. We saw it always, but our mobile medical facilities have to be flexible, mobile, hided, low signature, and we have to think about to defend ourselves to drones, to anything else. So this is something that I see personally, that we have now our old material, and to bring it now to these flexible and mobile settings, which is not easy. And this is, in my opinion, a big problem, because we're not talking about SOSTs or swords or small surgical units. We're talking from big wall, 1, 2 facilities. Then we do not have these experiences until now that we have to hide. So this is something we really have to think about. And if this phrase from a Roman a long time ago already said, okay, if you want peace, you have to prepare for war. So we do not have to train to fight, but we have to train to prepare, or to be prepared for these with war. And this is something that I don't think we already have in every mindset, that we have to change our thoughts and we have to talk about it. And it will be a little bit painful to change these things.
So what can we already do? First line of operation, we can take advantage of our own experiences. For example, in the Sahel, in the war in the Sahel, in the last decade, French with other nations were deployed in deserts with really wide and long evacuation distances from the point of injury to the first medical or medical surgical treatment facilities. We have described what we learned in this kind of prolonged casualty care in the Sahel, and we improve our medical practices in the field. We push blood far forward. We were able to train our medical teams to perform really high level of damage control with station during the several hours of medical evacuation. So it's a first learning.
Absolutely, and this was the time where Jean Keener was invented the prolonged field care, but if we are honest, there was 1 or 2 patients, and now we are talking about 30 or 100 patients who have this prolonged field care phase. And in this time, Jean always said, okay, it's outside the operational doctrine, and now we have to plan with these timelines for evacuation. So we learned something, but now we have to multiply the quantity.
We had also some experiences in European Special Operation Forces interoperability, and Matt knows this since he was a medical director for the Takuba task force. It brings together several nations from Europe. It was finally quite easy to act in interoperability between all these nations. So it's another experience that shows that medical teams are able to work together in interoperability and international task forces. Second line of operations, we definitively need to continue our collaborations. It's important to share data. Jennifer Gurney, and the Joint Trauma System advocates that say we can save lives with data. So we need to collect data. We need to collect data together. We need to analyze them together, and we need to adapt our respective doctrines together and to bring them into interoperability. We need to share science and experiences, and we can pay a great tribute to the Noble Slave initiative by Roman Kuziv. Roman Kuziv is a Ukrainian military medical doctor. We talked earlier about the systematic and deliberated attacks of healthcare facilities. So he proposed to get underground these medical facilities. The Noble Slave Organization described direct observations from the field, for example, with new technologies used in warfare as first-personal view drones, and compared them with one profiles in other settings. So it's important to continue this collaboration, this observation of direct field data reported.
Yeah, and as we already talked this morning, and what we try here personally by staying there and trying to show, okay, we have to work together, even when it's sometimes a little bit, crazy, that SOMA is sharing knowledge, CMC is sharing knowledge, and these conferences that we try also to bring together is the key to speak together, to know each other. And yeah, just a small anecdote. I was deployed for Sudan for the MEDEVAC vacation, and I just meet some SOS people there on the airport, and you just know each other. And this is the thing we need, that we need how we think, who is the other one, who is it trained, and what can we do together. And I think this big family brings us together and let us work and go through bad times together.
So it's true with the Combat Medical Care Association. It's true with the Special Operation Medical Association. We moved from last year's building interoperability through solid fundamentals to medical mobility empowering self-effectiveness, and it's really current and important issues when Europe is getting medically prepared to face large-scale combat operations. It's true also with other scientific network, for example, the TOR, trauma, hemostasis and oxygenation research in Europe, in Ireland, in Italy, and in Norway.
So, as I already said, this scientific collaboration is, in our opinion, the way to work afterwards and to bring a direct application to the battlefield.
Yeah, it works in the two directions. Scientific systems learn from the field, and when we are familiar with collaborations in scientific meetings, etc., it go up to the battlefield. What further can we do? Third line of operations, we need to change our way or our ways to do.
Sometimes for interoperability, this is just an example that we have to have the same language, the same nomenclature, and the same knowledge about what does each capability can do. We always talked, or SOFCOM said it for the SOS working group, that we try to see, okay, what kind of if you have a SOS, what is in the SOS? What can they do? And this is just the different tiers for Germany that we had for our All service members, combat lifesavers means like the normal infantry, special forces, and medical service members. And we just adapted, or not we, but the command adapted the name that in the field everybody knows if there's a combat medic, what is his capabilities, and is it just a thing that we have to learn the same language. ATLS was the first thing that we tried to have a same language with ABC. Afterwards is March. Now we need that if you're going to the Eastern Front and working in the multinational settings, that when there's a doctor, there's a doctor. When there's a paramedic, what can we do, or what can we expect, and how can we train together?
We need to change our medical support doctrines, and in the French military, we have recently, almost 1 year ago, changed our document of referent document for the French tactical combat casualty care, named Sauvetage au combat. And we try to put into this new doctrine some responses to mass casualties, to the use of thermobaric weapons, etc., etc. And we try to put also some special insight about interoperability into this document. Fourth line of operations, stronger together. You fight like you train. All the advices are sometimes the best ones, and so we need, since we will fight together, we need to train together. It was illustrated during the last Vigorous Warrior, and it will be repeated this year. It's the case also for other trainings.
So we have multiple trainings. Yoda was a nice and effective for soft and small surgery units, and Vigorous Warriors now for that role 2 and role 3 with 25 nations, more than 3,000 people. So this is the way we have to train together. But at least just for the Vigorous Warrior, for example, every of these multiple role 2 and 3 facilities were there, but they're just training each for themselves. So the next step would be to bring all these together and let them train together, not on the one country, one big training exercise, but we have to take patients from one facility to the other, and perhaps also sharing our teams together. That would be, in my opinion, the next step for these warriors.
Under joint medical command and control unit. We need to organize strategic MEDEVAC.
Now we're talking about taking care of the casualties at this frontier line, but how to bring all these casualties back home through different multiple ways: ship, air, train, or bus. And then we as Germany will be the hub for NATO for all these casualties, and there we have a lot of preparedness to do civil-military cooperations, but mostly I don't see really the whole way from all these casualties, bringing them home with personnel, with all these assets. So this is a big issue we have to talk about.
And obviously, we need to involve the civilian healthcare systems, and it's currently the case in France. There are some collaborations between the military medical system and the civilian one, just to be prepared and to organize things when hundreds and probably thousands of casualties will be back in France. Probably that the military medical teams will be deployed in operation, and the civilian medical teams will have to treat these patients who will be evacuated maybe after days or even more weeks or months after the injury. So we can we can't do the things alone. We need the support of other nations. We need the support of civilian healthcare system also. So take-home messages after our brief lectures about large-scale combat operation measure engagement. What we think is that first, medical challenges are new and huge. They are not totally new because we had already these experiences during major conflicts in the past history. Sorry. We had already these experiences in major conflicts in the last century, but we have probably forgotten some lessons during the 3 last decades of counter-terrorism and counter-insurgency operations, medical support. Second message is that medical superiority is definitively a game changer, and it's important to talk about it. It's important to get prepared in the medical aspects. It's a part of strategic signal sent to either our allied, but also to our enemies, just to say, okay, we are ready. Don't try. And third message, we are definitively stronger together. We need to continue soft-med interoperability, to train together, to build some command and control medical capabilities, and more importantly, to continue to gather data, innovations, etc. Three advices, lectures. And if you have some questions and comments, you're more than welcome. You're also more than welcome and at the next Paris Soft CMC conference in November. Merci beaucoup.
Thanks.
There are more and more hospitals actually closing down over there in Europe because of financial reasons. And
It's not good to hear, sorry.
it's not, can't you hear me?
It's almost as a French accent.
Oh, okay. There are more and more hospitals closing down in Europe because of financial reasons. However, you might need those resources, those beds later on, and I'm wondering how you're going to address that kind of propaganda.
Ich habe dich nicht verstanden. Sag mal nochmal.
Mamy nomea powyżej tyle finanse. Kommen immer gegen später die ihre gestartet. Sie die
Okay, this was a question about that in example Germany, many of small hospitals are closing, and how can we deal with all these things? But I think I do not have an answer for this. But that will be, certainly an issue. But I think this is really a national insight thing. So do not have any answer for this. Sorry. Any other? Thanks.
Yes, sir.
Cool.
Thank you for your presentation. My question is related to medical interoperability. And the U.S. military uses physician assistants a lot. And I was wondering how you view integrating American physician assistants from the military in these joint exercises, or in a LSCO environment where we are having patient flow from battlefield into civilian institutions.
Because the physician assistants.
Yes. We're thinking about it. We have some we begin to integrate PAs into our system as well. And at least, perhaps it's not in our line of care, these physician. But if we talk about it, if we know what anybody can do, I think with the clear name tag or like clear capability, we have to implement them, and we just have to know about each other and about the capabilities of a PA. So we are beginning in Germany to get these PAs also involved in our hospital, for example, and we have one at the moment, and we still have discussions. What can he do? Is it a student? Is it a physician? But we have to learn and we have to adapt. But this is one thing, yes.
Yeah. To answer, we need everybody on the desk. So including American physician assistants. Second answer, in France, we have organized different steps in the defense strategy. So I guess that their places will move according to the step of defense involved.
Thank you.
Thank you, sir.
Any final questions, folks? No? Thank you very much.
Thank you, Guy. Thank you, Mike. Merci.
That's it for today's podcast. Make sure to go to our website, www.prolongedfieldcare.org. Check out our free downloads and a ton of other helpful information. Grab a bag of our fresh roasted PFC coffee, links in the description below, and stay on the bleeding edge of combat and austere medicine. This is Dennis for the PFC podcast. Out.